Hi, good morning, everybody. We're going to be talking about SPECT-CT in MSK, musculoskeletal conditions this morning. So again, this is an extension on the bones talk that we did last year. So I'm going to talk a little bit about SPECT-CT, very little on SPECT-CT and MSK. I mean, we know why SPECT-CT is so useful. And then we're basically going to go down the body from head to feet. And then at the end, I'm going to talk about some new reconstruction techniques that are just arriving. In fact, whilst I'm speaking, the hospital I work at in London now has just bought one of these new machines that's been being tested by our physics team this week, which has these new reconstruction techniques. So the advantages of SPECT-CT, as we said in previous talks, lies in its better specificity. The ability to really see where uptake is and being able to correlate that to CT is very useful. It can be more sensitive because basically you can pick up small lesions which you might ignore if you just saw the SPECT or the planar imaging. But in reality, just remember to mute yourself as you join, please. In reality, you've only got a 40 centimeter field of view most of the time, unless you want to do 2 SPECT acquisitions, which is takes quite a lot of time, which obviously for a cancer you might feel is more indicated than it is for a SPECT study in a benign disease. So it does have limited use in things like multi-site disease. So for example, if you're dealing with a disseminated arthritis like rheumatoid arthritis, it may not be as useful. Also remember, outside of the chest and abdomen and pelvis, radiation doses are generally quite low. So you may want to change the parameters of the CT to give you a better quality CT, which may be important in being able to understand where you're having uptake. So you may want to look at the way that you do CT as well. So let's start off with head and neck. There's not very many papers just on bone imaging in head and neck. There was one published from Germany looking at 30 patients, but that was with malignant disease. But they did identify some benign disease. They noted that 17 had local bone metastases on planar imaging and MR, but 2 additional sites of METs were seen on SPECT-CT alone. And they claim there were no false positives or false negatives. Now, there's not really much data on this, but this is just to show you one of my patients who had pain and stiffness in their neck. And we were looking primarily for facet joint disease. But what you can see, in fact, is that if you look on the just the SPECT slice, on the sagittal slice, you've got some uptake, which is in the bodies of the vertebra. And when you look at the CT scan, you can see that there's these anterior osteophytes, and these line up very nicely with the uptake. And this is a condition called disseminated idiopathic sclerosing hyperostosis. And this is a condition which particularly affects middle-aged men. In fact, I have it as well. And nobody really understands what happens. So it's not degenerative osteophytes, it's an inflammatory osteophyte. And this is a very nice way to demonstrate it. Again, can you please remember to mute yourself? SPECT-CT in the spine, again, there are a few papers. There's a paper in the JNMT from a place in Australia under the wonderful name of Wagga Wagga, which is an Aboriginal name. And they looked at 80 patients with solitary sites of increased uptake in the spine. And they said that they could identify. What they did is they asked a panel of readers, nuclear medicine physicians, to read the scans and identify exactly where the uptake was. And on planar imaging, they just guessed, and they were about correct finally on 6%. But this increased nearly 80% with SPECT-CT. And then there were 31 false negatives on patients with planar imaging, but only 7 with SPECT-CT. So they showed that SPECT-CT really was very useful in looking at spinal conditions. And then there was more recently, there's a paper in World Neurology looking at SPECT-CT in back pain and enabling it to look at the extent of disc degeneration. And they found a very high concordance of SPECT-CT and the clinical picture. And 96% of the sites were presumed to be what's called a pain generator. And this is something that we see quite frequently, is this idea of the pain generator of being the site with most likely to be the source of pain. And there are several orthopedic surgeons who will do a SPECT-CT, let's say the spine, and then they will inject steroids in that area because they find that that gives us very good symptomatic response. So this is from a paper from the JNMT, and here you have a typical spine of somebody who may have some back pain. And if you look very carefully in L4, there's a blob. Is that in the body? Is it in a facet joint? Where is it? And that's the problem is that they, you just can't always see where these blobs are effectively. So by doing a SPECT-CT, you can see here, and it's unfortunately a black and white image, but you can see here that it actually localizes to part of the vertebral body. And this is a bit of degenerative sclerosis in the vertebral body. So the SPECT-CT does enable you to, and just in case you're not seeing it, it's this lighter area here, which is where the sort of fused image is. Now, I think this is the only black and white image I've got. Most of them are color. So this is a patient who has, again, you have a spine with a single dot. It's actually more obvious on the posterior than the anterior, which make you think that it could be to do with the posterior elements. But when you look at the SPECT-CT, in fact, this is a patient who's got a partial crush fracture, osteoporotic crush fracture. And that's why they've got increased uptake at that site. And it's not a metastasis or anything. Sometimes you get a surprise. So this is another patient, fairly normal anterior, bit of degenerative change. Posterior, there was a dot. And we did a SPECT-CT, and what we found was the dot was actually not in the patient at all. And for some method which is completely outfoxed us, they managed to get urinary skin contamination that far up their back, which I think is probably fairly difficult to do, but they did. And that was what we were seeing. But if you'd reported this in a patient maybe with breast cancer, you might think, oh, it could be a bone metastasis. Well, that would have been slightly embarrassing when you found out it was just urinary contamination. There's one special area in the spine where SPECT-CT is becoming increasingly useful. And this is some work that was done from a hospital in London called University College Hospital. And lots of people, for various reasons, get spinal fusions. This may be because they have a scoliosis or a kyphosis and they're trying to correct it. They may have a traumatic damage to their spine, for example, in a road traffic accident. I suppose a parachutist might as well. Or they may have had a metastasis in their spine, which has been treated, and then the vertebra sort of needs some support because there's very little bone left. So the they can be quite aggressive in the way that they treat this. And basically what they do is they put a fixation rod in and then they screw it into the vertebral bodies. But sometimes the patient gets pain afterwards. And here, this idea of the pain generator is extremely useful. So here you have somebody who's got a fusion. You can see they're being fused because they have a quite nasty kyphosis in their lumbar spine. And they've got a series of, sorry, I have to keep stopping to get people to come in. Okay. They get this pain, and the pain is basically due to the fact that it doesn't actually fix, and the bones are rubbing against each other. So they're getting like a malunion type event. And this is very, very metabolically active. So the idea of the pain generator really works in this kind of situation. So a little bit like a prosthetic joint where you get the metal rubbing against the bone. In these spinal fusions, you get two bits of the spine rubbing against each other. And if you can imagine, if you're walking or bending over or sitting, then they're going to rub against each other and be painful. So there's a few papers, they're all from the same group. And they found that, for example, it is a paper from Suna. They found that only SPECT-CT only was the right way to find a lesion in 8 out of 35 patients and allowed precise localization, and it changed management in 43%. Now, the image I've got is from a different paper, and this is this lesion in the lumbar spine. And you can see here at L2 to 3, the uptake is actually related to the screws that have gone in to support the device. And these screws are loose. And on the CT, there's a bit of sclerosis around that, but you can see how metabolically active they are. So this patient needs to have those screws removed, and then they need to have another type of fixation put in. So it can really direct management. Going to take a diversion down to the hand now, because that's the next area that people have found very useful. And when you're imaging a hand with SPECT-CT, there's various techniques that are used. Some people do the diving technique, where the patient lies on the bed with their hands and wrists inside the gamma camera and the rest of their body outside. If it's a single hand, it's possible just to sit the patient by the gamma camera heads. They put their hand in the center of the field of view, normally on a pillow, strapped on with some tape, and you can do the SPECT-CT that way. So this was a German paper. They looked at 51 patients with wrist pain. 48 lesions were seen in planar X-ray, 117 with just bone scans, 142 with SPECT-CT. And again, you're getting this number of around about 40% of patients where it changed patient management. This is one of their patients from their study. And this is from EJNMI research. A 25-year-old male with wrist pain, particularly worse when grabbing and lifting. They thought originally it was tendinitis. The X-ray doesn't show anything in the bones, but there is some edema around, so it sort of suggests there's something going on. They did a planar bone scan, and there is a blob. There's a blob of uptake, but where is that? And that's the problem, is that you can't really localize it. But in fact, if you do the SPECT-CT, it actually localizes to the lunate. And we've all heard of scaphoid fractures, but this was due to a lunate fracture. And that needs to be fixed surgically, otherwise the patient will not get any better. This is one of our patients. And again, we've done a bone scan, and there's a blob in a hand. Where is it? Well, it looks like it could be scaphoid, but when you do the SPECT-CT, not only can you localize it to the scaphoid, but you can localize it to the proximal scaphoid. And you can actually see there's the fracture line running across the scaphoid. It's an undisplaced scaphoid fracture. That still needs fixing. Sometimes you get a surprise. So this is another one of our patients, and this is the bone scan with a blob. But when you do the SPECT-CT, you find the blob is actually not in the bone, but is in the muscle. And the reason is, as you know, is that when you get muscle damage, you do get release of calcium, and it can localize bone tracers. Again, let's talk a little bit about osteomyelitis. This is using bone imaging, not white cell imaging. This is, sorry, it's 2019 paper. This is 85 patients with suspected osteomyelitis underwent SPECT-CT. And again, there was not quite the 40%, but in 17% of patients, SPECT-CT was more useful than by the planar or SPECT. So even with the pathology like osteomyelitis, you will get some improvement with SPECT-CT. So one of the areas we tend to look for this kind of infection is around hips and knees with prosthesis, which tends to be more common than just osteomyelitis on its own. It tends to be certainly in the developed world related to the placement of prosthesis or post-trauma. I understand in Africa, it can be different. In West Africa, for example, it's more commonly related to sickle disease, and you can get more spontaneous osteomyelitis in other groups. And in children, interestingly, there was a very nice paper from Red Cross Memorial in Cape Town showing that bone scanning may actually be negative in some children osteomyelitis. So I'm really only talking about adults where we have good experience with bone scintigraphy and osteomyelitis. Now, we quite often get asked to do a bone scan in a patient who's got a painful THR. Now, when we're doing SPECT-CT, then the metal becomes a bit of an issue. It can affect SPECT reconstruction. So you need to look at how that's been done. And most of the modern gamma cameras, SPECT-CT cameras, do have a metal artifact reconstruction method, which tries not to overcorrect the metal, so you don't get the hot spots you see around the metal. Those of you who've got new PET-CT scanners may find you have less issue around metal than those with older ones. That's because they're using this kind of software. Also around the hips, there's a problem with the bladder. So when you're doing reconstruction, bizarrely, the bladder does this thing called count stealing. So the computer thinks all the counts come from the bladder, so they can be difficult to interpret. So you may need some care in reading images in this area. This one's not too difficult, but you can see that we've got a wide empty bladder. That's not always possible. And this is a condition called Sappho. Yes, 3-year-old will be my end. I think also if they've got osteomyelitis, you can't guarantee to do a bone scan on them. This is a condition, inflammatory condition called Sappho, which is a fleeting, non-infective osteomyelitis related to patients, adults who have persistent acne. So it's quite and they get various different types of joint pain, but also they can get little periosteal microfractures in long bones. This patient, you can see these periosteal reactions here. And there is this sort of fairly low-grade uptake, which is consistent with sort of burnt-out Sappho. But you can see very nicely it localized into these areas of periosteal reaction, which you don't really see on the when you're looking at the SPECT alone. And these periosteal reactions are very typical of Sappho, so you can give a reasonable diagnosis with this kind of technique. Slightly more common, of course, is the total hip replacement. And here we have a bit more in the bladder, but we're still, the reconstructions cope with it. We have a chunk of metal, and here you can see some uptake on the distal side of the femur. And this is hyperostiotic bone, which you often get as a reaction around a prosthesis, and you can see that on the CT. So the CT helps you to read the bone scan, because you can use the CT appearances to firm up your diagnosis. Now, very interestingly, and it's very subtle, I don't think you'll see it, it's very subtle. There is a small area of focal uptake down here, and when you looked on the CT, just here, there's a little spiral fracture on one side of the femur, probably because of mechanical pressure from the end of the prosthesis, and that was what was causing the pain. It wasn't very hot on the bone scan, but you could just see a little bit of uptake there. What about the knees? Shall we move down to the knees? And again, this is some work that was published from University College London. And they looked at 60 patients who had problems after knee prosthesis. Now, knee prosthesis are common. Problems after knee prosthesis are common. And the knee is a much more unstable joint than the hip. So even with a knee replacement, you can get all sorts of problems. And they say you can get a synovitis, you can get problems with the patella rubbing against the prosthesis, which is very common. And also you can get infection as well. So this was a review of 60 patients. They found that SPECT-CT helped in 86%. And where they went to surgery, they know that SPECT-CT was correct in nearly 90% of patients. So this is a very common issue that we have. So a patient has a total knee replacement, and then about a year later, they start to develop more pain. It's a sort of ache type pain. And this pain is around the knee, not very well localized. But you do a SPECT-CT, and what you see is both on the sagittal view and on the transverse view, you see quite intense uptake at the back of the patella. And if this actually carries on, you can actually get the patella worn away. So you can actually see the destruction of the patella. And already you can see there's quite a little osteoporosis in that patella. So probably the only thing they can really do is remove the patella if this becomes a problem. Now, people don't like that because it makes it look a bit weird, not having a kneecap, but it does certainly improve the pain. This was another one of our patients. This is not with a prosthesis, it's just a normal knee that had persistent knee pain. What you can see here, this is a coronal view. So you've got the femoral condyles, you've got the tibia. And what this patient effectively has is a joint arthritis between the fibular head and the tibia. And that's what was causing the pain. And that was treated by local steroid injection. So we've gone from the head and we end up at the feet. Now, the feet, I'm going to spend a bit of time on because actually, generally, and I'm sure this has been your experience unless you're about 6, is that feet have a habit of hurting. If you go to the cradle of mankind up in Hotang, you'll get the story of how hominids moved from wandering around on 4 legs to 2 legs, and they didn't seem very good at it. They seemed to fall in the back of caves quite a bit, which is where their bones get found a few million years later. But the old goating up on your feet and walking around is very good if you want to spot either something to eat or a saber-toothed tiger that's trying to eat you, because it gives you the height to look over long savanna grass. But the problem is our feet aren't the world's best designed for that. So having carried the weight of people's bodies for their whole life, feet often hurt. The other thing is, if you remember anything about looking at feet, there's lots of bones. So a bit like the hand, it's quite difficult to localize. Now, MR is very popular way of looking at this, and you'll be told by MR radiologists that you only need an MR of the foot. But the point is that MR is not that helpful for 2 reasons. One is it doesn't really see bones very well. It does see bone edema, but bone edema is incredibly common. So, for example, they used to do MRs on the feet of professional soccer players, football players. And by the time they'd been a professional for 2 years, every single bone in their foot was positive on an MR scanner. but they didn't all have damage to their feet. It's just they get bone edema because of the repeated trauma. So it doesn't really tell you which one of those bones is the one which is causing the problem. Again, imaging, planar imaging is not that helpful because you can't really localize it to one of these bones. So SPECT-CT enables us to find the site of uptake. And the other thing is that two of the big pain generators are ligament insertions and enthesis, particularly Achilles and the plantar fascia, the two big ligaments that cause issues. And then you get these extra bones in ligaments called sesmoid bones. And they sometimes fracture or just get in the way and become pain generators. So this was some work that was published in Nuclear Medicine Communications, looking at 60 patients imaged with foot pain. And they looked at the SPECT-CT. Sorry, I keep trying to change this slide. It should say only one study is normal. I keep repeating the slide, but forgetting to save the change. And again, around about half the patients SPECT-CT change management. Now, because the feet have got all these bones, they have a various different kinds of pathologies. So this is the pathologies that were found. In fact, stress fractures were very common. Degenerative disease, then I guess you'd expect, and then this plantar fasciitis, chronic regional pain syndrome, gout, other ligament disease, impingements, midfoot fractures that are missed, post-surgical uptake, and then there's various things like Becher's disease, Charcot's, coalition problems, rheumatoid arthritis, sesamoid fractures. So whenever you're imaging the feet, expect the unexpected. So what happened to these patients? Well, interestingly, not everything did we find at change management, but in the 29 where we did, some of them, they went off to an orthostist, mainly to have a sort of shoe put on. Even those with stress fractures, they don't treat the stress fracture. What they do is they try and get the person to wear better shoes that supports the foot. And you're meant to just take some pain relief and walk until the bone strengthens up. Air cast boot was used for some of the trauma, pain clinic referrals. In fact, interestingly, only one patient went on to surgery out of that, but it did mean at least some management occurred. So this is a patient who'd had a previous fracture and still had a screw in place. And you can see the screw on the CT scan, and you can see there is a little bit of uptake on the bone scan, but it's not very high. But the bigger uptake is down here in the, this is the coronal view. So this is the posterior malleolus of around the tibia. And if you look very carefully, what's actually happened is the very tip of that malleolus has actually been pulled off. And that's why it's hot. This is another screw hole for a screw that was taken out. But the reason that there's pain there is because there's actually been a small avulsion fracture that needed to be fixed. This is a person who decided to go running. They hadn't been running before. They got some old trainers out of the cupboard and started running, and then got pain. And we thought it would be a stress fracture. And the stress fractures normally occur in the metatarsals. But in fact, what they've done is they cracked through their talus. This is actually a talus fracture. Again, the X-ray was normal. So this is a slightly unusual. Looks a bit like a knee, but this is actually a coronal view of the ankle. And again, this is after a fracture. And you can see that, again, they've moved taken out the screw that put the medial malleolus back on, but somewhere along the line, they forgot to check the lateral malleolus. And that is completely, there's a bit of an avulsion there, but even more subtle. If you look, there's a very hot area here. When you look on the CT, can you see that there is, in fact, a compression fracture of the distal tibia? So when they fractured it, they punched the distal tibia into itself. Now that actually needs a fixation across that joint because it's not going to heal otherwise. This is another patient with foot pain. So we got a blood pool, and then on the static, you've got uptake around the base of the big toe. And when you do the SPECT-CT, you find that this is a sesmoid bone, and these are little bones in the ligaments, and here it is under this is the metatarsal here. These are the proximal and distal planets of the big toe. And this is the sesmoid bone when it has just fractured, just broken into two. And that's what it is. And the best thing to do in that case is just to take that little bone out. So I'm going to finish off the talk by talking about some new advances in SPECT-CT. So some of the images I showed you were very good, but could we do better? Well, the better your CT, to be honest, the better your image on the CT part. And for orthopedic surgery, that's quite important. So if you have the option and you're allowed to, buy the best CT you can buy. You can also use iterative reconstruction techniques on the CT, not just in nuclear medicine, and use dose reduction. So that enables you to get better images. Now, the big thing that we've also done is looked at this thing called scatter correction. So as we know, whenever gamma rays interact with tissue, you get scatter. And that's what makes nuclear medicine images fuzzy. So could we use artificial intelligence effectively to defuzzy the image? And there's just coming through some very interesting software that enables you to do that. Also, there's lots of these multi-head cameras coming, which enables you to do quite rapid SPECT-CT. So you'll be able to do more SPECT-CT in more areas. You can do a whole body SPECT-CT on one of these machines in about 10 minutes. And these look like big CT scanners. Also, we can do quantification, which may or may not be useful. Now, just trying to explain how this works. So if you have, let's say you have an object such as, my drawing is not very good, so I apologize for that, but let's say this was a vertebra. So this is the edge of the vertebra, and the pink bit in the middle is the uptake in the middle of the vertebra. So that's what is in reality, what's happening there. But when we do a nuclear medicine SPECT scan, the way it's reconstructed, we see more activity in the middle of the circle, and we see less outside. But if you remember when we look at things like spines, we often see activity beyond the edge of the vertebra, and it's called spread function. So spread function is all to do with scatter and the Compton scatter diagram. However, we know that all this activity came from this area. So all this is scatter. So if you can use some bits of clever mathematics, you can use the CT shape to reconstruct what it would have been originally. Oops, sorry. So you can go back to that original image. So this is CT-based scatter correction. And these systems are very new. In fact, I asked somebody to provide an image, and they'd had a machine for 3 months and they still hadn't turned their program on, but they did for me. But this is an image from when this was being set up. This is a paper that's in the European Journal of Hybrid Imaging. And this is very typical what we see with the SPECT image A. So this colored image here, the SPECT image, it's a very nice SPECT image, but again, it's quite fuzzy, isn't it? And when we lay it over the CT, can you see how it extends beyond the bone? But if you use the bone to work out where that scatter comes from, you can actually get it to fit inside the bone. And in fact, if you do just look at the SPECT image now, it's actually got a really good resolution. You can see the uptake is localized in one very small area. Now, this is not benign, it's actually a metastasis. But this scatter correction, called XSPECT, enables you to basically use the CT scan to improve the resolution of SPECT. This is all very, very new. I mean, you may have one of these machines. As I said, we just got one going through its been accepted at my hospital. But I think it's an exciting new area, particularly in sort of orthopedic type of situations. So again, this is provided for me from the Siemens company that makes this particular program. And again, this is 3 reconstructions of the same patients. The patient was only scanned once, but it was reconstructed 3 different ways. So this is just a SPECT image. This is just a normal back projection. This is with CT attenuation correction, which is what most of us now use. But then when you use the XSPECT, can you just see how much clearer that image is and how much it actually looks like the spine that it came from? So these are very exciting new areas, really, and certainly no more, jabs about unclear medicine. Now, you may say, where should I use that? Well, I know that many of you may be wanting to go into private practice. And if you can imagine this kind of technique with orthopedic or sports injuries, as well as looking at metastatic bone scan, you can begin to see how this would be very attractive. And for those of us who work in state hospitals, obviously, it will really enable us to do a sort of one-stop shop of imaging, which will save money. And that's how we sold it to our the people with our money at our hospital, is that we wouldn't need the patients to have multiple investigations, but with this improvement, we could get a diagnosis on a single study. Also, we can use these techniques to do quantitative SPECT, and this work was done by Dale Bailey in Australia and published in 2014, and he used a phantom model to define the SUV, and he had it done with PET and SPECT, and he cross-correlated the SUV. Now, obviously, he used different tracers. He used F18 in PET and Technetium 99 in SPECT, and he was able to get equivalents to SUVs with SPECT-CT. So if you have the appropriate software now with this scatter correction, you can now also measure SUV. Now, that could be very useful if you are, for example, monitoring bone disease. So this is a paper that's just come out. It came out in, I think, May this year. And this was actually looking at patients with very normal and abnormal uptake in vertebra. And just as you would with a PET scan now, you can use these techniques. And again, look how good the registration is and how we no longer overlap the vertebral edge with these techniques. And there's a couple of things they found. They found that the uptake of MDP in men was slightly higher in the cervical spine, but slightly higher in females in the thoracic and lumbar spine. So men have more uptake in their neck. So maybe women are right when they say that men are more of a pain in the neck because they've got more bone turnover. And then they looked at looking at benign and malignant disease and SUVs. And they found that, in fact, if you actually do quantitative measurement, it may be possible to differentiate between benign and malignant disease, particularly in the lumbar spine, where the SUV is much higher for metastasis than it was for benign disease. Very early research, it needs to be correlated, it needs to be put together, but it is an exciting area which, bone scanning used to be considered something that was a bit boring, it's not as exciting as PET, but with these techniques, I think it's back in the game as actually a very useful and interesting technique. So SPECT-CT can be useful anywhere. It's useful in most areas, but seems to be of most requested in the foot, knees, and spine. I think it improves both sensitivity and specificity of bone scintigraphy. But these new techniques are really, I think, going to revolutionize it. I think within a decade, we'll find that we're all using these new techniques in terms of producing higher quality imaging.